How has transitional cell carcinoma diagnosis evolved? Imagine how much medical science has advanced over the years in detecting and understanding cancers like transitional cell carcinoma. This type of cancer starts in the lining of the urinary tract, especially in the renal pelvis and ureter. Over the past century, the way doctors diagnose this cancer has changed dramatically, thanks to new technology and growing scientific knowledge. In the early 1900s, doctors mainly relied on symptoms like blood in the urine or pain to suspect cancer. They would perform physical exams and look at tissue under a microscope to identify abnormal cells. By the 1920s, pathologists developed grading systems based on how many cells looked indifferentiated or abnormal, helping predict how aggressive the cancer might be. During the 1930s and 1940s, classifications focused on how the tumor looked, whether it was papillary or solid, and how deep it invaded tissue, which helped estimate prognosis. The introduction of cystoscopy in the mid-20th century was a game-changer. This procedure involves inserting a thin, lighted tube into the bladder and urinary tract, allowing doctors to see tumors directly. During cystoscopy, they could take tissue samples, or biopsies, for microscopic examination. This made diagnosis much more accurate and allowed doctors to determine the tumor's grade and stage more reliably. Traditional imaging methods like intravenous pyelography and retrograde pyelography were used to spot abnormalities in the urinary tract. However, these techniques had limitations, especially for small or flat lesions. As technology improved, computed tomography scans, especially court urography, became the standard. These scans produced detailed three-dimensional images of the kidneys, ureters, and bladder, making it easier to detect tumors early, especially in the upper urinary tract. In recent decades, scientists have uncovered more about the genetic and molecular makeup of transitional cell carcinoma. They have identified specific mutations and changes in genes like RB1 that influence how the cancer develops and progresses. While molecular testing is not yet routine in diagnosis, it holds promise for future personalized treatments and better risk assessment. Because transitional cell carcinoma often affects multiple areas and tends to recur even after treatment, doctors now follow strict surveillance protocols. This includes regular imaging, urine tests to look for cancer cells, and repeat cystoscopies. This ongoing monitoring helps catch recurrences early and manage the disease more effectively. Today, diagnosing this cancer involves a combination of clinical evaluation, advanced imaging like court urography, and endoscopic procedures with biopsy. Pathologists analyze tissue samples to determine how abnormal the cells are and how far the cancer has spread. This information guides treatment choices and helps predict outcomes. For anyone concerned about kidney health or symptoms like blood in the urine, understanding this evolution highlights the importance of early detection. Advances in imaging and biology continue to improve how we find and treat transitional cell carcinoma, offering hope for better outcomes. Always remember, if you notice symptoms or have risk factors, consulting a healthcare professional is the best step for personalized care.